You can still see the screen, right?
Yes.
Okay, all right, let's begin pain. Our official definition of pain is that of Marge McCaffrey. She uh, she defines pain as whatever the patient says it is, existing wherever the patient says it exists. So it's purely subjective. This is universal. Everybody, everywhere has experienced some sort of pain. Goes beyond physical, can be shaped by biological, sociocultural, psychological factors. It has different types as well. Regardless of the type of pain, it is highly subjective. We don't experience pain the same as everybody else. So it's a unique personal experience. The worst thing we could do is ask the patient to prove that they are in pain. Our job is to assess and manage pain through nursing and as well as pharmacologic interventions. So it is not our duty, or we have no right to ask the patient to prove to us that they are in pain. For instance, you've all heard of people being branded as seekers, right? For those who work in the hospital here, have you ever heard of that term?
Yes,
What is the
Professor.
term,
Yes.
Professor? What did you say? I missed that.
Some people who are frequently admitted in the hospital for the same thing
Right.
and frequently ask for pain medications, they tend
Uh-huh.
to be labeled as drug seekers.
Yeah. Uh-huh.
Right. So
Yeah.
it happens in the hospital. I'm not saying I've never done that. Yes, of course I have. I'm human too. But as a nurse, really, because of the definition of pain, that it is highly subjective, does that give us that right, though, to question the patient's report?
No.
No, it tells you here that the patient is the best source of reporting for pain. While there are physical signs and symptoms, it does not exist in all patients. You cannot really match a patient's facial expressions or behavior to that of pain, because aside from the personal experience, the pain being subjective, we also have varieties in expressing pain. In my family, for instance, it is never acceptable to, especially with the males, that's just how we were brought up. If you're in pain, just suck it up. You can say you're in pain. It's not acceptable to be moaning, crying about it. If you do, no, you'll be looked down upon, and literally, we were scolded for if we behaved like that.
Professor, are you recording?
Yes, I am. I think so. Yes, we are recording. But I don't think you need this recording. I mean, the pain is pretty simple. But anyway, here's the definition. As I mentioned, we're using McCaffrey's here, Margot McCaffrey. Her definition is this, that it's whatever the experiencing person says it is. So however the patient describes it, knowing, burning, whatever description they use, take it as it is. Let me just explain the gate control theory. So this is based on the belief that pain, just as any other sensation like pleasure, um, the pleasure we get from food, from film, for instance, eating, having our favorite drink, being with um, people we love, um, playing a game, or cold, hot, any other sensation travels through nerve fibers. The theory goes that pleasurable nerve fibers travel through larger nerve fibers because we have larger and smaller nerve fibers. Unpleasant things like including pain, sadness, whatever negative or unpleasant sensations, feelings, thoughts travel through smaller nerve fibers because every sensation, every stimulus, including pain, travels up and down the spinal cord. Now, like I was saying, the pleasurable ones travel through larger nerve fibers, while unpleasant sensations travel through smaller nerve fibers. Now, what do you think, which do you think is easier to stimulate? Something large or something tiny?
Large.
Large, because you touch it, it's easier to see. You can touch it, you can hold it, it's easier to stimulate. Whereas tiny, small nerve fibers are harder. I'll give you an example. I mean, we're mostly adults here. So during sexual intercourse, for instance, right? Do you feel any pain?
Depends on which side you're on.
Well, generally speaking, is sexual intercourse or sex painful or pleasurable?
There's a
Mostly
pleasure
pleasurable.
experience.
Yeah, for the most part, it's pleasurable, right? Afterwards, though, afterwards, do you feel, let's say it was extra long, for instance, do you feel sore and there's pain now?
Yeah.
Yeah. So why is that? Why is it during the
Sensation.
activity there was no pain at all? Afterwards, though, then you start feeling it. That is one proof that when larger nerve fibers are stimulated, the smaller nerve fibers that carry pain or other unpleasant sensations are therefore blocked. So that is the gate control theory. Now, another example is there is this group of homeopathic midwives. They had this practice of course they deliver at home, right? So they work with um, pregnant women who want to deliver at home. How they do it is the woman gives birth in a bathtub. So the woman stays in the bathtub about half full of water, so their perineum is submerged. During labor, the partner, the husband, or whoever the partner is, um, at the peak of a uterine contraction, which is for moms here, you know, who've ever went into labor, that's the most painful part of labor. So at the height of a uterine contraction, when the fundus, you know, really turns hard because the uterus is contracting, the partner is asked to stimulate the woman's clitoris to initiate to trigger a orgasm. So that is another proof that and it worked. They did not use any epidurals. They did not use any pharmacologic means. It was all natural birth. So no pain medications at all. That's all they did was soothing, back rubs. So the mom was also, you know, whoever else is helping, or the midwife will be rubbing the patient's back, you know, giving back rubs, and the partner again is instructed to stimulate the clitoris at the height of the contraction, so that based on this gate control theory again is Once you stimulate the large nerve fibers, the gate going to the brain, I mean, this gate is imaginary. Okay, this is just an idea that once the large nerve fibers are stimulated, it closes the gate. So therefore, signals coming from smaller nerve fibers are therefore blocked and therefore cannot be felt. Right. So this is just an idea. The same gate control theory is now used as the mechanism by which pain medications work. So same thing when you take opioids or any other analgesic for that matter, they also use the same gate control theory that once you take the pain medication, although the let's say for opioids for instance, the opioids don't really stop the pain. The pain stimulus is there. What they're altering is the brain's interpretation of the pain. Therefore, instead of feeling it, the brain interprets it differently, meaning they alter the interpretation of the pain stimulus. So therefore, it's not interpreted as pain anymore. Therefore, the gate is closed, no pain. All right. So anyway, that's just what the gate control theory means. Let's proceed with acute and chronic pain. So we have acute, which has they're not only differentiated by the duration but also by the nature, the sensation, the patient's description is also different between acute and chronic pain. One main difference is the the period. How long has the pain been? um, Examples of acute pain is every now and then we get abdominal pain from, let's say, when we have diarrhea or when we get upset stomach, for instance, we get abdominal pain. So that's acute type, meaning sudden onset and they also go away all of a sudden. Chronic pain, on the other hand, is different because this one is um, harder to treat. They are more long term. They don't really go away 100%, meaning you can make it feel better, but it doesn't really go away. Another example is joint pain from arthritis. These types of pain are not really acute. They'll have some painful episodes, more painful than usual, but these types of pain don't go away. They're there. I'm not saying that the patient would feel it 24/7, but for example, every time the patient moves, the pain is there. That's no longer acute because the patient has been sustaining that pain for a while, meaning it's something that probably isn't going to go away. So here, acute pain is sudden in onset, short duration, and we typically know what's causing it. Let's say a surgical incision, yes, because I had surgery, so that's acute pain. In chronic pain, you may, or sometimes we don't know why there is pain. There's something we call also chronic pain syndrome, wherein doctors have done testing after testing. They could not find a physiologic reason for the pain. Another example is look at neuropathic pain from you've discussed phantom limb pain in fundamentals.
Yes.
Yeah.
Okay, right. So this is so this is pain experienced by amputees. Let's say they lost their left leg, but then they feel like their left leg is hurting. It's not like it's there, meaning you can't, of course, the leg's not there, but then it feels like the left leg, it's not even the left thigh. So if you ask them, maybe you meant the left thigh or your left hip, and no, it's my left leg which is missing. Okay, that's an example of another chronic pain, but this one is more neuropathic type. And because the patient feels it, it's real to the patient, it has to be treated. Okay, again, pain is highly subjective. That's pain. It's real. It has. Here's a side-by-side comparison, table 11.1. So here's description for chronic pain that persists for 3 to 6 months or even longer than that. Here's another similar to phantom limb pain. Diabetics also complain of neuropathic pain. These are more nerve type pain, just like phantom limb pain and fibromyalgia. I don't know any patients with fibromyalgia. I just heard about them, but never really took care of one. Everybody else, phantom limb pain, I've seen that patients like that, or diabetics, thousands, but never come across fibromyalgia. But they do say that it's a knowing type of pain. You can't really pinpoint where it is. It can be around your neck, your shoulder. It follows a certain pattern consistent with nerve connections, usually in the torso. Um, and then you've also heard of sciatic nerve pain, or maybe some of you have that. It's not really pain per se, but this uncomfortable sensation running down from your right or left buttock all the way to your leg. I've had that, so I understand how people, who express that sensation, that type of discomfort. That it's hard to drive, sometimes hard to walk, hard to get out of bed, or even worse, sitting still. You can't sit still, you have to keep shifting because it's really uncomfortable. Chronic pain can have a exacerbation from time to time, meaning they experience pain on top of the pain that they experience every day. This type of pain is usually more severe than usual. They have an acute type of nature. They have chronic pain, but they get these acute pains in between. That's what we call breakthrough pain. They are short-term bursts of acute pain. This is in the background of chronic pain. Do you understand what I mean? For instance, fibromyalgia, for instance, or those with cancer pain. So patients with cancer have a certain type of pain that they deal with every day, from morning till night. But in between, they experience these more acute, more severe outbursts of pain wherever their cancer is, and it does not respond to the usual pain medication that they're already taking as a maintenance, as scheduled doses. Because of that, patients will have to receive a different type of opioid to address this type of pain, because their chronic pain medications will not be effective against this type of pain. Cancer pain used to be a different category in itself. The World Health Organization used to classify them separately, meaning we had acute pain, we had chronic pain, and then we had cancer pain. Now they put it back again under chronic pain, chronic malignant pain. So this is pain in cancer. Nociceptive pain is the pain caused by these noxious stimuli on tissues, bones, joints, muscles, or your abdominal organs. So let's say, such as a headache, for instance, your knee hurts, or you got a bruise, or you pulled a muscle, you had surgery. These types of pain are all nociceptive, meaning you can touch that part of the body and you feel that pain. Neuropathic, on the other hand, is different. You can't really pinpoint exactly where the pain is, meaning there's no one spot like right there, right. Let's say you're pointing to a specific spot on your stomach, or on your limb, for instance, that you can really you can pinpoint exactly where the pain is. Neuropathic pain is different. You can't really pinpoint exactly where the pain source is from. Nociceptive pain is further subdivided into different types. Cutaneous is more superficial, and then when it comes from deeper tissues such as joints, bones, or muscles, it's now called somatic pain. And then if it's in your organs, let's say when you're having severe cramping, or for the females here, when you have your monthly periods, when you have those, what do you call them? When you get those um, abdominal pain, what do you guys?
Cramps?
So something like that, like your uterus is hurting, so including our stomach. So those are now visceral pain. It feels different, right? Like abdominal pain is not the same as when you have a muscle pain, or let's say you twist your ankle. It's different, right? It's not the same sensation. Referred pain is kind of um, neuropathic, but not really, because the sensation in referred pain is still nociceptive in nature, meaning the sensation is similar to, let's say, a chest pain, such as when you're having a heart attack, but then let's say a tooth pain, for instance. You have a toothache. Sometimes the pain is felt on another area of the mouth, wherein the 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 tooth with the cavity is in another place, but then the pain is further inches away from the where the tooth is really. Have you had that? That's an example of referred pain, but nonetheless, it is still nociceptive. The sensation of neuropathic pain, these are your descriptions. Shooting, stinging, pins and needles, whereas your description for nociceptive usually are, um, what are the descriptions here? Right here, pressure or a pin prick, or you say describing as a ache, sharp, dull pain, whatever. Right here you have dull, ache. Whereas the description for neuropathic is different from that of nociceptive. Have you heard of the term paresthesias?
Yes.
Okay, paresthesias are right. So you remember when your leg falls asleep, right? When you, let's say, you squat sitting in one area for one area too long, and then when you get up, your 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 leg, you can't move it because it gets numb, and then gets very sensitive. Like when you hit it, it's not painful, but it makes you laugh. Painful, but
His leg is dead.
yeah, I don't know how to describe it. You know, like when you know it's hurting, you can't really move, and then your friends like hit it, like they slap it, then and it makes it worse, but then it goes away later. So that type of pain, for instance, that's neuropathic as well, because really what caused that is you were sitting too long on your limb, you're sitting in one spot, so the nerves were irritated, or yeah, they were deprived of the blood supply for a while, so they become they result in those sensations. So that's a description of paresthesias. So patients with fibromyalgia or any other type of neuropathic pain, including shingles, although shingles is so much more painful compared to any other pain, because it'll be like electricity, like electric shocks as described by patients. But nonetheless, these are all neuropathic type of pain. Um, Most people with this type of pain have a vague report of their complaints. They sometimes you think you've heard all the description, but then patients come up with something else. You know, like they have a different description of the pain that they're feeling. Here are again, besides acute and chronic, we further divide nociceptive pain into cutaneous, somatic, visceral, and neuropathic. These are the descriptions. Here, cutaneous, tender, sharp, itchy. This one, dull, achy, cramping, crushing, stabbing, sore. All right. This post-herpetic neuralgia is shingles. This is this is what we call the pain in shingles, is post-herpetic neuralgia. We'll skip the processing pain management messages. This is really not testable. This is just describing how the nerve pathways lead to the location of the pain. That's not really, I mean, how are we going to test it? So we'll skip all that. Let's go now to assessment. We'll skip all these. Even this one, I don't think we need. All right, let's begin here. When did you talk about patient-controlled analgesia? No, you've never talked about this, PCA?
PCA Professor?
Yeah, PCA.
When do we talk about it, you
After
say?
surgery.
All right, so
Surgery.
patients, okay, yeah, those are all correct. Patients who have either severe pain or even chronic pain are prescribed PCA. PCA is not only IV, but the most common form we see in hospitals is IV. We do have PO. There are machines that dispense tablets. Doesn't have to be uh, IV. So how it does is the patient still presses a button just like they would in a PCA, IV PCA. And then instead of them getting the IV, the machine dispenses a tablet. And therefore it is technically still PCA, although this one is PO. IV PCA allows the patient who have very poorly controlled pain to regain control over it, meaning they don't have to wait for the nurse to give them the medication. So they press a button and the machine delivers a preset dose uh, set by the doctor. Of course, the nurse programs the machine, the PCA machine. Typically, we have a PCA dose, meaning let's say press the button, they get 1 or 2 milligrams of morphine, meperidine, or hydromorphone, whichever the doctor orders. And there's also um, a continuous dose, meaning whether they basal dose, sorry, there's also a basal dose, meaning whether they press the button or not, the patient is receiving morphine continuously, say 0.1 milligrams, for instance, every hour. All right. On top of that, they will have a PCA dose. So the PCA dose is the dose they receive when they press the button. However, the basal rate will continue to infuse whether they press the button or not. Some patients are on pure PCA, meaning no basal rate. That means they won't get any morphine unless they press the button. There's always the potential for overdose. However, it's less likely because we have limits program on the PCA. The pump has a 4-hour lockout, meaning the patient only receives a maximum dose every 4 hours. So they can press that button every second or twice a second for all I care. They will not get the medication more than what's programmed into the pump. And there's also this 15-minute lockout wherein they can only get so much medication every 15 minutes. So again, no matter how many times they press the button, it does not give it to them because they have already exceeded the 15-minute lockout. We still take the data though, because every time the patient presses the button, the pump records it. It's on the pump screen, and then you can review the history, telling you, oh, how many times did the patient press it? Let's say you see that it was pressed 200 times in 1 hour. What does that tell you?
Be 200 times the regular dose.
No, I mean, when you looked at the history, you saw that this patient pressed the button 100 times in the last hour. So what can you say about the patient's pain management?
Acute pain?
Yes, acute or chronic, but what is it saying about the pain management?
Oh.
Pain is not under control.
Okay, of course, we can say that it wasn't effectively managed, right? Because why would they press it 200 times? That means, were they in pain?
Yes.
Yes, the assumption is yes, because why would you press the button if you were not in pain, right? So therefore, that's something to review. It tells us you report that to the doctor, and of course you assess the patient. How is your pain management? Are you satisfied with the dose? Then you get the patient's feedback, and then you give the data also to the doctor. Okay, it's saying the patient is reporting poor pain control, and I looked at the history. She pressed the button 200 times in the last hour, and whatever data you have. Next question is, who can use a PCA?
Only the patient.
Can children use a PCA?
No.
What have you got? What has the children done to you? Why would you not give PCA to a child if a child is in pain? Say a child with cancer. You're not going to give them. Yes, we can. We give PCAs to small children. The only requirement is that they know they're alert and oriented, that you can tell them instructions, they're able to follow instructions, and that they understand what the machine does. What about if you have a paraplegic or a quadriplegic? Can they get a PCA?
No.
But the quadriplegic is alert and oriented.
Yes, they can. Once their arms are able to move.
Yes, they can. Again, the only requirement, what did I say was the only requirement? Patient is alert and oriented, and
Alert
that
and
they
oriented.
are cognitively able. All right, it didn't say the patient had to have an arm or a finger. There are ways, there are other, if you're concerned that, oh, they can't press the button, there are other ways to activate the PCA. It doesn't have to be a button. We have blow straws now. Patient just needs, as long as they can move their head and they can put the straw in their mouth, they can blow into that straw and it activates the button for the PCA. They can do the same if they want to activate the call bell. There's another straw that they put their mouth into and then they blow into that to activate a call button. Okay, so we have those things now. Same thing as with, we have paraplegics with T8 fracture, for instance, T6, T8 fracture. Those guys can drive a car because we now have hand controls, so they don't have to use their legs to hit the gas pedal or the brake pedal. We have hand controls now. It's been around actually. I saw it in the 80s movie in the original Captain America. I don't know if you guys were old enough to see that. Anyway, when I was a kid, 80, 81, yeah, I loved that Captain America show. He was paraplegic and he drove around in a conversion van, and his motorcycle was in the van, and then he, drives on, and the van opens up, and then out goes Captain America with his shield in front of the motorcycle. Pretty cool. Anyway, moving on. Let's go to this part. Again, is not testable. Let's go now to the assessment. We will include the assessment tool for the older adults. Okay, so one of the topic questions on the exam are your assessment tools. So how do we assess pain? All right, so we know that this is the fifth vital sign, meaning during your routine vital sign assessment, you should always ask the patient, are you in pain? Regarding that, when it says PRN, when a medication is listed as PRN, what does that mean?
As needed,
Right. Yeah, I know. Yeah, it's as needed. But how do you administer it?
based on the
Do you,
patient's pain scale.
okay, do you wait for the patient to ask you to complain?
No, but you do
Okay, very
frequent
good.
assessment.
Right. When something is ordered as needed, your duty really as a nurse is to ask the patient, do you have whatever the PRN is? Do you have nausea? Do you have pain? Do you have gas? Whatever that PRN order is. All right. Offer, or if you don't like that word, assess the patient for those as needed circumstances. PRNs for, I think it's Greek, it's a pro re nata, which means as the need arises or as the circumstance arises. So therefore, you should offer it. Don't wait. Don't say, let's say at the end of the shift, oh, he never complained of pain, so I never gave anything. Well, did you ask the patient? Remember, the patients vary. Some patients don't express pain. Um, some patients say, what's your pain level, ma'am? 10. And then they're on the phone talking to a friend, laughing and having fun. But when they report pain, they say it's 10. Does that mean they're lying?
No.
No,
No, because it's
just
subjective.
exactly. We have different ways of expressing pain. Just like I shared with you, we're not in my family. We're not allowed to
Okay.
express pain by bawling down and crying or curling up in a fetal position. We can't.
What if the cultures do that?
It's just how we are. It's embarrassing if you do that. So um we just suck it up and then just be quiet, and then when asked, okay, we say, yeah, 10 is pretty bad. But um don't base your pain assessment on behavior, or facial expressions, right? It's always subjective. It has to be the patient's self-report. If you doubt, let's say, yeah, we're human. We can see, I don't think this patient's really in pain. All you can do is just document your observations. Let's say patient reported 10 out of 10, but then the patient does not appear in distress. There is no grimacing noted. There was no um, they appear relaxed. There is no guarding behavior. They're not in a fetal position. They are seated um, comfortably in a semi-Fowler's position, or they're lying in bed, or you can even add, oh, they're talking on the phone with their friend. Okay, if you want, you can add all those, but really, that's not going to make a difference because you are still obligated to address the pain regardless of how they behave, how they express that pain, or even the lack of expression of that pain. So we have the usual, which is the numeric pain scale. We ask everybody 0 to 10. Try using others. That way you can have experience in evaluating. Well, let's use another one because we the numeric pain scale. We also have visual analog scales. Um, we have the for children, yeah, we have the Wong Baker faces, right? Did you do that in peds already?
No, not in PEDS, but med surg from last semester.
Oh, okay. There you go. So you know the um, example. So here's your descriptive pain intensity scale. Here's the numeric pain scale. Here's the visual analog. Here's the Wong Baker faces. What about for cognitively impaired patients? Say patients with autism or Down syndrome, uh, trisomy 21, um, no, patients with developmental delays, or even dementia patients. What should we use for them? They have pain too. Might have difficulty with
Professor,
Baker
do
faces
we
or
watch the vitals?
sorry.
Do we look at the vitals, like if they're tacky
Okay,
or
again,
their face expression?
okay, I'll emphasize again that what is pain? Is there physical evidence of pain?
No.
Purely subjective. If there are vital signs changes, it does not prove or disprove the presence or absence of pain. All vital signs will show you is probably something else, but not pain. If you put, let's say we have a ward, we have a unit of full of post-op patients, all in pain. Chances are, if you take the vital signs, you'll have variations. All of them are in pain, but yet some patients will have an increase in heart rate. Some will be completely normal. Some will have an elevated blood pressure. Some will have low blood pressure. So there's really no evidence that says there are vital sign changes, that pain impacts vital signs. For acute pain, severe acute pain, yeah, maybe, but it's not going to be consistent because over time, if this patient, do you develop adaptation to anything? Let's say if you've had pain just now, severe pain now, versus if it's severe pain, but then you've had it for uh, a whole year now, um, will your reaction to it be the same as the first time?
No.
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 Okay, so here, barriers. So good thing you brought that up. Barriers to this is here. Some clinicians believe that including a subjective numerical assessment of pain at the same time objective data such as blood pressure and heart rate are collected overstates the qualitative usefulness of pain assessment information, especially because this measures only a single dimension of pain. Plus, again, there's really no evidence that shows that pain causes changes in vital signs. There's really none. Some people, yeah, but since it's not universal, therefore that's not proof of pain. So basically, again, pain is purely subjective. Do not ask the patient to prove. Let's say you're saying, oh, you're in pain, and then let's say you're doubting, right? And then let's check your vital signs, and then you show the patient, oh, look, your vital signs are all normal. How come you're saying you're in pain? Your vital signs don't show that you're in pain. Imagine that. Put yourself in the patient's shoes, so because now you have to show the nurse that you have elevated vital signs before they'll give you pain medication. How's that gonna feel? You get what I'm saying? So still rely on, yeah, the self-report. Okay, it's not fair. I mean, it just goes against um, our duty. Okay, our pledge as RNs, as nurse professionals, that we're gonna medicate pain, we're gonna manage our patient's discomfort, and we of course take the patient's subjective report as sole proof for the pain. Here's the full pain assessment. So we don't just ask somebody tells you, oh, I have pain. Can I have pain medication, please? Okay, how bad is your pain? Is that enough? It should be complete. So when you are doing your chart assessments now on any EHR, you'll be asked to complete your assessment. So when you click pain, yes, it will now ask you these. There will be drop down buttons. Don't worry, you'll get faster at it. You'll get used to the drop down choices and answers. So it'll ask you onset, provocation, so OPQRST, provocation, quality, region, and radiation, severity. So this is now the number or whatever pain intensity scale you're using. And then time and duration, the AAA is aggravating, alleviating, or associated clinical manifestations. Later in cancer, I forgot what chapter that is. I think it's 14. What chapter is pain? Is this chapter 11?
Yes.
Yes. I think cancer is chapter 14. Maybe. Anyway, there's another acronym there. The acronym is OLD carts. No, old like old person, and then cart like a shopping cart. Old carts. It's similar to the OPQRST, although that one is more specific to cancer pain. As far as
You're just gonna
pain expression, yeah, so you
say,
have here, yeah, go
use
ahead.
the cognitively impaired.
Oh yeah, cognitively impaired. So we have a tool called here. This is page 211. The tool is called Pain Assessment in Advanced Dementia tool. So PainAD. This one has similar contents as the FLAC. So in infants, we use FLAC, which is facial expression, leg activity, crying, and consolability, FLACC. They share some similarities, but not the same terms used. I believe PainAd has something with irritability, their ability to be similar instead of consolability, which is referring to a small baby. They use a different term because it's just not appropriate to use a infant pain assessment, pain intensity tool on an old person, right? It's just not appropriate. So they developed this separate tool for either advanced dementia people or those who are either cognitively impaired or unconscious patients. So let's say you have a patient who is intubated on a mechanical ventilator. You can use a similar tool, since they technically are cognitively impaired because you sedated the patient. Right? So similar criteria for assessing. They don't have it here. They just mentioned, I don't have the example. Maybe it's here. So here they have 5 pain indicators. I know in the FLAC, which is for infants, it's facial expression, leg activity, and crying and consolability. Something similar for but we use different terms. You can also ask the assistance of family members or caregivers who are familiar with the patient, because the patient has typical behavior. However, when they have pain, the behavior changes. So maybe the family members or caregivers are aware of these, that, oh, he does that when he's in pain. All right, so we can use this data because specific patients have peculiar behavior specific to them. So that's also, they can be your source of information as well, because sometimes it's just difficult with dementia patients or old, again, or cognitively impaired patients. Let's see what the pain ad is. One, two, three. Okay, here's the 5. Okay, so they do still have the consolability. So here, breathing, negative vocalization, facial expression, body language, and consolability. And these are your observations. And if you had that, then you score them, and that would pretty much be your pain level. Make sense? Hello?
Yes.
Okay, so here, if you, let's say they have these, then that's a 2, so times 5, then that's 10. All right. So this is an example. So they have similar one for FLAC. If you observe those, and then you'll have still a score, and that's basically your pain intensity. Because again, these people have dementia, they're unable to give you a pain scale, a pain rating. So this will help us do a more educated assessment rather than just guessing or estimating. I think, yeah, I'll give him, one Tylenol instead of two. So at least you have a basis, a scientific, a science-based assessment tool. So that takes care of our assessment. Let's go now to our management. Okay, page, oh, still page 211. All right. Please use non-pharmacologic pain relief as well. Some of you, or most nurses I see in practice, they go straight for the MAR. When some patient complain of pain, they go straight to the MAR. We do have non-pharmacologic pain relief. Typically, I'm also guilty of that. I go back to my non-pharmacologic interventions when I run out of options, meaning a patient's asking for pain and it's, let's say, 3 in the morning. I have nothing else. I've already given them what I could give based on the orders. So now I have to be creative. So I go back to nursing interventions. That's nursing diagnosis. Yeah. See the several nursing diagnoses that result from pain. So besides pain, you have all other problems here associated with pain. They have fatigue, constipation, probably related to immobility because of the pain or from the pain medications, or risk for falls because it could also be from both. So here you have a more than just pain resulting from pain, meaning it affects your sleep, your social interactions, even sexual patterns. Okay, it affects everything. Here are our options now. So let's begin with non-opioids. You have analgesics, you have your Tylenol, you have your salicylates, aspirin, although we hardly use aspirin for pain now. We only use this for cardiac purposes as an antithrombic therapy. So we use Tylenol, and then NSAIDs. These are all non-opioids. As far as questions on the tests, of course, it will be on limits, how much maximum you can give for each medication, and then more importantly, the side effects, contraindications. We haven't talked about peptic ulcer disease yet, but NSAIDs is the #2 cause of peptic ulcer disease because the drug works by inhibiting prostaglandin. So the action is inhibits prostaglandin synthesis, and prostaglandin is a neurotransmitter. However, besides being a neurotransmitter, prostaglandins are also vasodilators. So they um, they supply blood, help supply blood to the cells in your GI tract that produce mucus. So therefore, if you inhibit prostaglandin, there will be less blood flow going to those cells that produce mucus, and we need that mucus in order to protect your stomach and your GI tract, your intestines, from the stomach acids. So no mucus lining, the mucosal wall is exposed to the acid, you get ulcers. Okay, so that's how NSAIDs do that. Same thing, same prostaglandin is also needed in the nephrons of the kidneys. So the kidney nephrons need prostaglandin in order to get blood supply. If you take too much NSAIDs, therefore, it can therefore damage blood supply to the nephrons, and therefore you'll have kidney failure. So that's number 2. Number 3 for NSAIDs is they're contraindicated for patients with cardiac history. That's something new that came out in the last, I want to say, 8 years now. So if you have a patient with cardiac history, especially an MI, they should not be taking NSAIDs. Has still something to do with the prostaglandin blocking. So here, I mentioned the kidneys already. I did mention the peptic ulcer, right? It should be somewhere here. We have combination drugs now, so instead of giving single drug class, we now combine them. For instance, we can combine Tylenol with hydrocodone, making Percocet. So hydrocodone, which is it's oxycodone. Oxycodone with Tylenol is called Percocet. Or oxycodone with aspirin is Percodan. Or oxycodone with ibuprofen is Combinox. Then it's hydrocodone. Hydrocodone with Tylenol is Lortab or Vicodin. Or hydrocodone with ibuprofen is Vicoprofen. So now you have the benefit of 2 drugs. You have a non-opioid plus an opioid working 2 different ways to address pain. Right, they're the of course, you've heard of these. These are on the street. They're very highly abused. But when used correctly, they are very, very effective for acute and chronic pain. No, I don't have a question on the half-life. You can skip table 11.4. All right, so for aspirin, here tells you we don't really use this anymore. See, this is the usual, more frequent use for aspirin. So same prostaglandin inhibition. They inhibit platelet aggregation, therefore useful for preventing blood clots. So useful in patients with history of MI or stroke. Here's the risk for bleeding. Remember, aspirin is an NSAID, so it works the same as ibuprofen, etc. So here's the bleeding tendencies, and here's a different type of NSAID, COX inhibitors, cyclooxygenase. This is they're going to inhibit COX-1 or COX-2. Again, regardless of what that says, they really lead to inhibition of prostaglandin synthesis. And here is the GI tract I mentioned earlier. They cause ulcers, and therefore once these ulcers form, there are a risk for bleeding. Also here, they're contraindicated in the 3rd trimester of pregnancy because they can increase the chance of premature labor. So here's a warning for I believe this is celecoxib. I think it was celecoxib. Oh no, it's this one. Rofecoxib was the one that's pulled out because of the MI relation. Here's what I mentioned about the dosing. So Tylenol, you can give a gram per dose and then maximum of 3 grams in 24 hours. You can still give it for patients with healthy livers, but again, do not exceed this. And definitely try to use something else if the patient has liver disease already. So Tylenol is very hard on the liver. Here it's metabolized in the liver and excreted in the kidney. So therefore, if you have a patient who have diseased liver already, then no. Or if there's no other option, then lower doses if the patient has any liver disease. Here's a safety alert, definitely testable regarding Tylenol. Be careful with the total dose because you may have a patient who's on Tylenol alone or the combination drugs we talked about earlier. Remember hydrocodone and oxycodone? These things right here. Since Percocet has Tylenol with it, so be careful. The same thing also with Lortab or Vicodin, because the hydrocodone here is added with Tylenol. So be careful about the total the patient is giving. You'll know because it'll say on the package. So let's say oxycodone, Percocet comes in 5/500. That means it has 5 milligrams of oxycodone and 500 milligrams of Tylenol. Same thing for Lortab or Vicodin. It'll say 5 or 10 milligrams of hydrocodone /500 or /325 of Tylenol. Just be aware of the total because some doctors order this and Tylenol at the same time. So they'll say for moderate to severe pain, give this every 4 hours, 1 to 2 tablets every 4, and then you have a separate order for mild pain. Let's say they'll have Tylenol 325 or 500 milligrams every 4 hours. Just be aware of the total the patient is getting now, because you could easily reach 3 grams in 24 hours. Ibuprofen comes in IV also. This is the IV form, ketorolac. Tylenol also comes IV. Ofirmib. Let's see if it's here. No, it's not here. The spelling is OFIRMEV, I think. OFIRMEV. Ofirmib is IV Tylenol. They usually for post-op patients, especially if it's routine, let's say appendectomy or gallbladder surgery. Those are the patients who are given IV Tylenol. We do ask the patient if it is effective. Okay, but if we give it round the clock, they're usually pain-free with Tylenol infusion. But of course, we monitor the liver enzymes during the therapy. Okay, here are your nursing responsibilities now, table 11.5. So for each one, aspirin, what do you monitor? Ibuprofen, they again, and NSAID, so kidney, and to some extent also liver. Tylenol, definitely liver. Ketorolac, NSAID, IV NSAID. Here's the COX-2 inhibitor, platelets, and because this is still a NSAID. Steroids help with pain management by decreasing inflammation. Not applicable for everybody, but let's say inflammation-related pain, such as lupus, for instance, um, rheumatoid arthritis patients benefit from steroids. Multiple sclerosis patients benefit from steroids. So all these chronic autoimmune conditions are given steroids for pain. Here are your side effects. For high dose or sustained corticosteroids, because again, they are given daily, and over time they develop these conditions right here. What did you learn in pharmacology about steroids? Do you stop them abruptly?
Taper out.
Okay, all right, very good. Here is the consequence. So taper discontinuation is preferred over sudden cessation, because this is what's going to happen. You'll have adrenal suppression. So the patient will die from adrenal insufficiency or adrenal crisis. When we take something over time, so let's say you're taking steroids, right? Remember, your body naturally produces steroids. If you keep giving them steroids, what happens to your own body's ability to produce steroids? Because you're taking it every day. So is the adrenal gland, which normally produces steroids, still gonna be competent in producing steroids?
No.
No, they get lazy, right? Because they get lazy, once you stop this, all of a sudden, can they make up for the difference? Let's say they're a backup soldiers, right? But these soldiers are not, in shape. They're just laying there, big bellies now, out of shape. So when the first regiment are sustains a lot of casualties, can they now be good reinforcements?
No.
No. So same exact idea. So when you stop, therefore, the steroids all of a sudden, then the patient goes into adrenal crisis, which are all fatal. Patients goes into shock, severe hypotension. They'll go into hypoglycemia, and then they'll go into hyperkalemia. Those are the three that can kill the patient. We'll talk about those again in another semester, but that's basically the danger of suddenly stopping steroids. It's not minor. They could die. Make sure patients know that. This one, local anesthetics, they can be injected or applied as a patch. We have lidocaine patches here, lidocaine. Again, they are either injected as a block or used as topical patches. Here's a safety alert because they look alike. Another topical is MLA. This stands for eutectic mixture of local anesthetics. It works for some people, not really in my experience. These are topical ointments you can use for, let's say here, when you're starting an IV and you have a really nervous patient, meaning really like having a nervous breakdown because they are afraid of a needle. So they can use this. You apply it 45 to 60 minutes before you stick them. If applied correctly, it works, but I just very skeptical about it because it's not like the patient won't feel the needle. But anyway, it's better than nothing. So it's more of you still use it because there's this psychological thing about it, that you believe, oh, we put an anesthetic here, okay, this should be pain-free now. But of course, when you stick them, just get it over with, because you're already there anyway. You already stuck them, so just make sure you do a good job so you didn't waste the opportunity. All right. So that's what EMLA is for. You can also use it for inserting a Foley. Of course, if the doctor orders, some patients will have, especially spinal cord injury patients, they'll have a complication called autonomic dysreflexia. So to avoid that, we'll put EMLA first before we insert a Foley. In mostly paraplegics, those with spinal cord injuries of T thoracic 6 or higher. We're out of time, so I'll stop here for your quiz next week up to page 193, up to EMLA. All right.
Alrighty.
Okay, we'll continue next week.
Okay, thank you.
Thank you.
Ah.
Thank you, Professor.